Welcome to IM Updates. This is Yen. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from May 29th to June the 5th. Here's the overview. On May the 29th, the International Cardio-Oncology Society and Multinational Association of Supportive Care in Cancer published a clinical practice statement on prevention and management of cardiovascular disease in adults with cancer. 5 overarching clinical practice recommendations are provided. First, cancer care providers must identify pre-existing cardiovascular disease and cardiovascular risk factors like hypertension, diabetes, smoking, and obesity before starting cancer therapy. High-risk patients should have baseline cardiac biomarkers like troponin and BNP and be referred to cardio-oncology specialists. Second, risk mitigation before and during therapy, including lifestyle modifications, optimize comorbidities, and reduce cardiotoxic exposure. Third, assess patients at major transitions, like new or changing therapy, new symptoms, or when using drugs that affect cardiovascular risk, like steroids. Fourth, post-treatment surveillance plan, including annual cardiovascular risk assessment, including symptoms plus risk factors by primary care. Fifth, routine cardiac imaging is not routinely recommended for asymptomatic metastatic cancer patients on lifelong therapy, unless needed for treatment optimization. On May 30th, the Heart Failure Association, the European Association of Preventive Cardiology, and the Association of Cardiovascular Nursing and Allied Professions of the European Society of Cardiology and the ESA Council on Hypertension published a scientific statement on prevention of heart failure. Noted that the most powerful new drivers are metabolic disorders like obesity, diabetes, and chronic kidney disease, causing HFpEF, not just coronary artery disease. SGLT2 inhibitors are the first glucose-lowering drugs proven to prevent heart failure in diabetic patients. Semaglutide then showed modest heart failure prevention benefit and significant benefit in obesity-related HFpEF. Finerenone reduces new-onset HFpEF in diabetic chronic kidney disease patients. Statins, however, notably fail to show a protective effect against heart failure in randomized trials. There's also expansion of risk factors well beyond traditional cardiovascular risks, including female-specific factors, cancer therapy, substance misuse, infections and vaccinations, air pollution, and socioeconomic status. Intensive systolic blood pressure target less than 120 millimeters of mercury reduces heart failure risk by 38% from SPRINT trial, even in diabetic patients. For physical activity, quantified prevention begins at 2,735 steps per day, up from 2,000, with optimal benefit at 7,126 steps a day. Anti-proBNP or BNP and high-sensitive troponin are validated to predict incident heart failure. Use PCP-HF, PREVENT, or SCORE2-HF, specifically calibrated to predict incident heart failure. On June 1st, American Heart Association published a scientific statement on the role of physical activity in obesity treatment and cardiometabolic health. Key findings include physical activity improves cardiometabolic health independently of weight loss. Physical activity alone rarely produces clinically meaningful weight loss unless levels are very high, from 225 to 420 minutes per week. Physical activity augments weight loss when combined with diet, adds 1.2 to 1.7 kilograms. Resistance training preserves lean mass during weight loss, which is critical for older adults. Higher physical activity levels, more than 200 to 300 minutes per week, are associated with better weight loss maintenance. Physical activity with GLP-1 receptor agonists or bariatric surgery may provide additional weight loss and fitness benefits. On June the 1st, Adamo published Clinical Practice Guideline for Metastatic Breast Cancer, Diagnosis, Treatment, and Follow-up. Metastatic breast cancer management is rapidly evolving. Essential practices include biopsy at recurrence to reassess ER, PGR, HER2, and perform necessary molecular testing like PIK3CA, ESR1, BRCA, AKT1, PTEN, and PD-L1. Prioritize CDK4 or 6 inhibitors plus endocrine therapy in first-line luminal metastatic breast cancer. Use ADCs strategically, like T-DXd for HER2 positive and HER2 low, sacituzumab govitecan for TNBC, and datopotamab deruxtecan for ER positive. Manage brain metastasis actively with SRT and CNS active systemic agents like T-DXd or tucatinib. Incorporate patient-report outcomes, quality of life, and multidisciplinary supportive care at every stage. On June the 2nd, EBMT published consensus recommendations on HLA matching in contemporary hematopoietic cell transplantation. HLA matching remains critical, but its relative importance has changed. Post-transplant cyclophosphamide has significantly reduced the negative impact of HLA mismatches. Younger donor age is now a major factor, sometimes outweighing a single HLA mismatch. DSA screening is mandatory for mismatched transplants. Functional mismatch models like TCE or PBM can guide donor selection in non-post-transplant cyclophosphamide regimens. HLA loss testing is essential for relapse management after mismatch HCT. Pediatric and non-malignant disease require different prioritization, which is matching over age. On June the 2nd, NCCN Guidelines for Thyroid Carcinoma version 2.2026 was published. Key changes include expanded molecular testing to ALK, dMMR, MSI, and TMB. ctDNA only if tissue unavailable. 4 tiers of MTC risk, the highest, high, moderate, low, with specific surgery timing were defined. Next CT or MRI with contrast is recommended as pre-op imaging more often. Brain imaging before systemic therapy for advanced disease is recommended. Radioactive iodine for minimal extrathyroidal extension is explicitly not warranted. Stop surveillance after 10 to 15 years if low risk or no recurrence. Neck ultrasound every 1 to 3 years for 5 to 8 years. Then stop. Systemic therapy added lenvatinib plus pembrolizumab, lutetium dotatate, ipilimumab plus nivolumab, and recommend calcium 12,000 mg per day plus vitamin D 1,000 IU per day for TSH suppression. On June the 5th, American Society of Gastrointestinal Endoscopy published guideline on endoscopic management of benign and malignant colonic strictures. For malignant obstruction, uncovered colonic stents are suggested as bridge to surgery. For higher primary anastomosis, lower stroma rate, and for palliation to achieve shorter hospital stay and fewer adverse events. However, stenting may increase cancer recurrence risk. In extracolonic malignancy, stenting is feasible but less successful than for colorectal cancer. For benign strictures, endoscopic balloon dilation or EBD remains first-line therapy because of higher success, lower adverse events than stents or stricturotomy. Stricturotomy reduces recurrence but increases bleeding risk. Lumaprozine metal stents or LAMS may be considered for short refractory anastomic strictures. Bevacizumab use warrants multidisciplinary discussion given potential perforation risk. Avoid stents in potentially curable non-colorectal cancer malignancies and as first line for benign strictures. We don't have much of new FDA approvals this week, so that's all for today. Enjoy your weekend and see you next week.